topic, wide complex tachycardia management in the ED. So I've told our audience from all sort of background, medical officers from districts, emergency physicians, cardiology fellows, and also medical officers. So it's a bit confusing. It was a bit confusing for me how to break it down. So I've decided to make it as simple as possible and just discuss a few cases. But before that, I would like to go through some objectives. My objective is to understand the importance and clinical consequences of making the right diagnosis of wide complex tachycardia and get familiar with some of the different etiologies. So what comprises this wide complex tachycardia and the stepwise approach. So I'm not going to talk about the Brugada algorithm and Verity algorithm because I believe there are other topics later which are going to discuss about SVT aberrancy versus VT. So the clinical pulse, one of the most common lethal errors made in arrhythmia diagnosis is to mistake VT for SVT and treat with verapamil, diltiazem, and adenosine, where all of these are blocking the AV node. So therefore, all wide complex tachycardia should be assumed to be VT until proven otherwise. So some of the bedside clues. So history, advanced heart disease, okay, and then any congenital heart disease, any previous heart surgery done before, and sometimes you can see Canon A waves. These are associated with AV dissociation. And if the patient is hemodynamically unstable, think VT and act accordingly until proven otherwise. So maneuvers, the response of the arrhythmia to maneuvers may provide insight to the mechanism of the wide complex tachycardia. Carotid sinus pressure, they enhance vagal tone, depresses sinus and AV nodal activity. So if the wide complex tachycardia is VT, they are unaffected by vagal maneuvers such as carotid sinus pressure or Valsalva. They may slow or block retrograde conduction, exposes AV dissociation. Rarely VT terminates in response to carotid sinus pressure. So these are my differential diagnoses. So when do we say it's wide complex tachycardia? When the rate is more than 100 beats per minute, so and the QRS width is more than 120 milliseconds. So the next question is whether are they similar? The QRS, are they similar, monomorphic or polymorphic? So more common we have monomorphic wide complex tachycardias. If they are monomorphic wide complex tachycardia, they are further divided into supraventricular or ventricular in origin. So if supraventricular, they are under this category. Bundle branch aberrancy we have to rule out. Metabolic causes or drug induced or antidromic AVRT. Ventricular means either VT, pacemaker, or accelerated idioventricular rhythm. So first thing is check whether are they regular. The RR interval, are they regular or not? So marked irregularity of RR interval occurs in atrial fibrillation with aberrant conduction and also polymorphic VT. Next is axis. A right superior axis from negative 92 plus minus 180 is a northwest axis, strongly suggests VT. Later I will show a slide. What do I mean by this? So in exception to antidromic AVRT in Wolff-Parkinson-White syndrome. So this is some of the axes. Later I'll show a proper slide. So in general, wider QRS favors VT. In a RBBB like wide complex tachycardia, if the duration is more than 140, suggests VT. In LBBB, if more than 160, suggests VT as well. In an analysis of several studies, a QRS duration more than 160 was a strong predictor of VT. Likelihood ratio 20 to 1. A QRS duration less than 140 millisecond does not exclude VT. I'm not sure whether have you all heard about septal VT or fascicular VT or ILVT. Concordance. So concordance is present when the QRS complexes in all 6 precordial leads V1 to V6 are monophasic with the same polarity. For example, negative or positive concordance. So presence of concordance strongly suggests VT. Absence is not helpful diagnostically. Higher specificity for positive concordance. So here I'll show some example. So this is V1 to V6, all are pointing downwards. So this is negative concordance. As you can see, the foci is likely from anterior moving towards posterior. And if the foci is at the posterior moving towards anterior, you will have positive concordance. So V1 to V6 all will be upright. AV dissociation. AV dissociation is characterized by atrial activity that is independent of ventricular activity. Atrial rate slower than the ventricular rate diagnostic of VT. Absence of AV dissociation in VT. AV dissociation may be present but not obvious on the ECG. The ventricular impulses conduct backwards through the AV node and capture the atrium, preventing AV dissociation. So example, so later I'll show you all an example of the ECG. So PP and RR intervals are different. PR intervals are variable. There is no association between P and QRS complexes. The presence of a P wave with some but not all QRS complexes. So fusion beats. What are fusion beats? Fusion beats, we have two types of beats. One is a fusion beat, another is a capture beat. So in this lead, you can see this is a fusion beat and this is a capture beat. There's a sinus before the QRS. So these are the normal sinus beats of the patient, and these are wide broad complex tachycardias. So this is likely to be VT. So capture beats I've already explained. So I'll go to my first case. So Mr. KA, he's a 22 years old gentleman. So he has no known medical history previously. He presented with history of sudden onset palpitations. His VP was 138/88. He has no fever, and his saturation under room air is 100%. So this is the ECG on presentation to ED. I'll give you all a moment to have a look at the ECG, analyze it, because we're going to have a poll after this. Okay. So what is your next step of action? Back to the ECG, back to the presentation. Okay, can we have the poll? Oh, so interesting. 29% have chosen IV verapamil 5 mg, 24% have chose defibrillation, 24% none of the above. Synchronized cardioversion 18%, adenosine 6 mg. So let's go through the ECG first. So the correct answer is IV verapamil 5 mg. Why? Let's go through. So the first step in recognizing a problem is to recognize that it does exist. So is our ECG wide complex tachycardia or not? So this is the ECG. Look at the ECG carefully. The QRS is about 3 small box. So this is about 120 millisecond. Just now we said any QRS more than 120 is white, but this is just borderline. So is this really white? Let's go through. Let's dissect the ECG. So look at the long lead 2. What do you see there? So you see a regular RR interval ECG. So this is white in the sense that it's 120 milliseconds. So 120 is borderline white. So we still have to take it as white. And what do you see there? These are capture beats. These are different morphology. This QRS and this QRS are different, and this QRS also different. Okay. Look at the ECG. You cannot say that's an artifact because in each of the leads there is a different looking QRS. Here also and here also. So these are most likely, and before this QRS you can see a P wave. So these are most likely a capture beat. So next is analyze the axis. The AVR, what does the AVR show here? And the AVL, both are upright. Okay, I hope you all can appreciate that. All are pointing upright. Next, look at lead 1 and lead AVF. They are down right. Okay, so lead AVR AVL is pointing upwards, lead 1 and AVL is pointing downwards. So the axis is, so you look at the AVR and AVL and AVR, so means if they are pointing upright means, so the lesion is definitely coming from below, right? Okay, so and then just now we saw 1 and AVF is pointing downward. So lead 1 and AVF, they are here. So they are pointing downward. So that means the foci is somewhere from here and it's going upwards. So this is ventricular in origin. So this is likely to be ventricular tachycardia. So why if ventricular tachycardia, just now we said don't give verapamil because it's lethal. Then why in this case we have given verapamil? Because this is a different type of VT. This is called fascicular VT or idiopathic left ventricular tachycardia. In this kind of patients with fascicular tachycardia, verapamil, they are also called verapamil sensitive VT. So this is the type of VT which are only very sensitive to verapamil, and the VT morphology QRS won't be that wide. They can be narrowish because they originate from the septal area or the fascicular area. So a bit of the anti-arrhythmic classification. So class 1 we have sodium channel blockers. Sorry for the busy slide. Beta blockers. Class 2. Class 3 is potassium channel blockers, and class 4 is calcium channel blockers. So these are you all can go through this. This can easily available in the net. So next question. This is a 60 years old lady. She has post aortic valve replacement. She complained of sudden onset shortness of breath. Please look at the ECG carefully because we're going to have our next poll in a while. I'll give you all some time to digest the ECG. Okay. So upon assessment, she was drowsy with coolish peripheries. BP was 90/50. Saturation under room air was 91%. She appeared tachypneic. So what is our next approach? Go back to the ECG. Okay. What happened? Sorry for the technical glitch. Okay, so I'll go back to the previous the ECG again. So this is the ECG on presentation. Does it look wide? Does it look regular or irregular, or it's narrow? But clinically she's drowsy, BP borderline. Saturation, she's clearly not saturating well and appears in respiratory distress. So, okay, sorry. Okay, go to the poll. They have answered. Okay, good. So, oh, not finished. Still ongoing. Okay, so voting is closed. Okay, go back to go back. So in this case, she's clearly unstable. She's drowsy, BP is low, and she's having heart failure like symptoms because of the respiratory distress as well. So, and the thing is, she still has pulse. So whenever someone has pulse, what we do next is, so if in the guideline they already said if patient becomes unstable, perform immediate synchronized cardioversion. I hope it's clear. Okay. Next. So let's dissect this ECG. What are we dealing with? So this is a lady. She had a history of aortic valve replacement. She has some sort of manipulation done to her heart before. And this is a ECG. Look at the V1. What are you seeing? You're seeing a white QRS complex followed by a very constant P wave looking like morphology there, and the QRS is white. Duration is 200 millisecond. And look at the axis, 1 and AVL. 1 is downward, AVL is upward, AVR is upward. And look at lead 2, RR is regular, 240 milliseconds, and the heart rate is about 225 beats per minute. So there's a P wave, there's a QRS. So the P wave is regularly inverted. So there is no VA dissociation. So the P and there's some sort of connection, so 1-to-1 conduction, and the extreme axis deviation heart rate is 225. So this sort of patient, RS interval is about 40 millisecond. So, and there is no dissociation, as I said. So right bundle branch block with tall right rabbit ear. So in VT we have left rabbit ear, which will be looking taller. So when we go through the Brugada algorithm, so everything is no. So the R to S interval is 40 millisecond only, not more than 100 millisecond. The AV is not dissociated, and the morphology for criteria VT present, no. So this is likely to be SVT. So we have given her adenosine, and this is what happened after the adenosine. So if you look at so she had some sort of this is a strip after that. So she has some sort of, again, the P wave here slowed down, and then the P wave started to point, but somehow she went back to tachycardia. So she didn't respond well to adenosine. So our diagnosis is now either AT with aberrancy or antidromic AVRT. So this is a baseline ECG. So any question about that case later, you all can post up in the Slido. If you have time, you can go through. The next case is a 41 years old Chinese lady. She has underlying hypertension under district clinic follow-up. She presented with palpitation, 2017, lasted about 1 to 2 hours, relief after rash associated with chest tightness. She claimed previously had multiple episodes of chest pain, less than 5 times occur while jogging, lasted about 1 to 2 minutes but resolved spontaneously. She went to the GP diagnosed as monomorphic VT and repeated ECG in our hospital. The tachycardia resolved spontaneously. So look at this ECG, analyze it. I'll give you all some moment. I only have 2 minutes 40 seconds left. Yes. Huh? So please describe the ECG. Saidu. What do you all think about the ECG? Is it regular? Is it irregular? Is it narrow or is it wide? Okay, I agree. It's an irregular wide complex tachycardia. Okay, go back to the. So look at the ECG. It's a wide complex tachycardia. Everyone agree, but look at the VT morphology, and this is the VT morphology is something I got from the Google just for comparison. Looks more regular than our ECG, right? And look at V1. Our right rabbit ear is higher than the normal VT looking, which will be left rabbit ear looking taller. So this is the ECG after we have cardioverted this patient. So what do you see?
Delta.
There is an obvious shortening of the PR with the delta wave-like features. Okay, so this is a Wolff-Parkinson-White type A. So short PR interval, and there is a irregular RR interval. So this is pre-excited AF. So these kind of patients need to be urgently referred to us because there is a SPARI. If the RR interval less than 250 milliseconds when they are tachycardic, they need to be ablated because they have higher risk of sudden cardiac death. So next, please look at this ECG. This is another patient. This patient presented with sudden onset of drowsiness. So there's going to be a pole in view of running of time, we're going to make it short. So how will you manage this patient?
Magnesium sulfate.
Oh, excellent. So the answer is correct. It's max sulf. So for that, you need to know what's actually happening in the ECG. So this is a
Tosal.
very, very like a polymorphic kind of feature, but it's actually like a yo-yoing like a tosa the poa. Okay, so if you look at that, so this is tosa the poa. Max sulf is the correct management for this patient. So another patient, 45 years old lady, she has end-stage renal failure on regular HD. Please look at the ECG. Okay.
Okay. Calcium.
You can start the poll now. How do you manage this patient?
Calcium.
There's something quite peculiar about the QRS of this patient. Oh, okay, so you all are really excellent crowd now. So IV calcium gluconate is the answer. Why? Because
Okay.
the QRS is extremely wide, right? It's very, very broad. So in this sort of patients, especially in an end-stage renal failure patient, you have to suspect hyperkalemia. So when there is hyperkalemic patients, when there are toxic metabolite patients, they will have a wide QRS complex. So we need to, if they are still stable, we can always take the opportunity to check the bloods, but and to rule out hyperkalemia and all of those other factors, including acidosis and so on. Okay, with that, I think that's all about my topic.